Welcome back to part 2 of disease-specific diets. So we're going to talk about the gastrointestinal conditions, particularly, and those can be particularly challenging. Some of our nutrients are absorbed through our intestines, and so that can be an issue. First, we're going to talk about GI upset, nausea, vomiting, and diarrhea. The problems associated with these include dehydration, loss of essential electrolytes, malabsorption, and malnutrition. And yes, even metabolic alkalosis and acidosis. The gastric fluid contains chloride, and it's balanced with sodium and potassium and hydrogen. The loss of chloride causes the hydrogen loss, which abruptly increases bicarb. The abrupt increase in the bicarb causes a bicarb loss in the urine, which in turn drops the urine pH. The initial loss of sodium is followed by an increase in potassium excretion, which results in hypokalemia. Metabolic alkalosis can also be called hypochloremia alkalosis. This would be expected with vomiting, since it causes a loss of bicarb accumulation. And metabolic acidosis or hyperkalemia acidosis, because the kidneys reabsorb chloride in the response to the GI secretion loss. Diets recommended for these folks are a bland diet, usually a brat diet, mostly used for kids, and that's bread, rice, applesauce, and toast. NPO, replenishment of fluids and electrolytes, whether it be IV fluids, isotonic fluids, or by mouth. And then to restart a diet on clear liquids at room temperature and advance as tolerated slowly. Nutritional monitoring include INO, serum electrolytes, monitors the stools for consistency, color, and quantity, and food tolerances, daily weights, and these are some of the electrolytes: potassium, sodium, chloride, magnesium, that would be monitored. GERD, or gastric esophageal reflux disease, is a condition where the lower esophageal sphincter is opened and allows the backflow of gastric contents. The associated problems are dysphagia, which is difficulty swallowing, increased pressure, abdominal bloating, dyspepsia, which is indigestion, esophagitis, pyrosis, which is heartburn, odophobia, which is painful swallowing, regurgitation, and even aspiration. And in the picture, you can see where the sphincter is closed between the esophagus and the stomach, and then on the other side with the GERD, how it's open and the yellow arrows indicating that the backflow of the contents. A diet recommended is an increased protein diet, avoiding fatty fried foods, coffee, tea, carbonated beverages, alcohol, spicy foods, oranges and other citric fruits, acidic foods such as tomatoes, onions, chocolate, peppermint, and spearmint. Strategies to help with this include smaller, frequent meals, limited fluids with meals, and eating 2 to 3 hours before bedtime. Monitoring and teaching, you want to do weight reduction, choose foods thoroughly and slowly, remain upright 2 hours after eating, elevate the head of the bed 6 to 8 inches, and most likely there's blocks that they can elevate the bed, so they're laying at more of a slant to keep that contents down into the stomach. Avoid medications that irritate the esophagus, and keeping a food diary, and seek medical attention when needed for further workup. Also avoiding the medications to avoid include ibuprofen and ibuprofen containing medications, as well as the NSAIDs, the non-steroidal anti-inflammatory drugs. Inflammatory GI disease, which we're going to talk about Crohn's disease and ulcerative colitis. Crohn's disease is it's a group of chronic immune disorders with an unclear etiology. There's multiple factors that affect it, such as environmental factors, immunologic factors, infectious agents, genetic susceptibility, and different gut bacteria. Crohn's disease affects the small intestine, which results in diarrhea and even malnutrition because the small intestine absorbs some of those nutrients. And also, ulcerative colitis, or UC, affects the colon and the rectum, and it gets inflamed. UC affects the innermost lining of the large intestines. The diet, there is no specific diet that has been scientifically based to support any particular diet. They do come into an agreement that a low residue or a low roughage diet is beneficial. Some diets that have been thought to help with this but have not been scientifically studied include specific carbohydrate diets, SCD, the Paleolithic diet or paleo diet, or the anti-inflammatory diet. In some cases, when people have been NBO for a long period of time, total parental nutrition, which is an alternative source to solid foods, may be indicated, and they need vitamins and minerals, increase the fiber and decrease fat for the diarrhea. Nutritional monitoring, baseline serum chemistries, CBC, labs, particularly if the TPN is being used, which are electrolytes, the BUN, 24-hour urine may be collected, creatinine and blood glucose, INO, and anemia is associated with lifelong nutritional problems, so B12 and folic acid replacements are necessary. Intestinal blockages or obstructions. It can disrupt the normal peristalsis in the bowel. It can either be mechanical or non-mechanical. Mechanical would be an occlusion. Whether in the small bowel, it could be adhesions, hernias, neoplasms, or voluses. In the large intestines, it could be carcinoma, diverticulitis, inflammatory bowel disease, or benign tumors. Non-mechanical could be neuromuscular or vascular disorders, which could result in a paralytic ileus. Nutritional problems, again, we're going to see dehydration and electrolyte imbalances. Constipation with the blockages is possible. Nausea, vomiting, and abdominal pain. And they may also rupture their bowel and have to have immediate surgery to have that repaired or removed. Dietary measures as treatment, nasogastric tube to low intermittent suction. And again, with that, you have to be careful because you're losing that gastric secretions and those gastric acids. So you're going to be more prone to fluid and electrolyte imbalances, as well as that metabolic acidosis and alkalosis.